It's my pleasure to introduce Dr. Kim Yonkers, who's the chair of the Department of Psychiatry and the Katz Family Chair in the Department of Psychiatry, who will introduce today's speaker.
Recording in progress.
Oh, she's telling you that.
This is sort of like logging on to log on before you actually get to the real treat of today. Let me just tell you a little bit about Dr. Katherine Callaghan, who is on faculty here in the Department of OB-GYN, but also has a secondary appointment. So Dr. Callaghan received her BA from Middlebury College, and my daughter graduated from Middlebury College 2 years ago. So let me just tell you a little bit about Middlebury College, which is, I think when you actually matriculate and go on campus, they issue you a pair of Birkenstocks. Is that right?
And a Patagonia.
And a Patagonia, right, sweater or vest or something like that. So you can go around the TAM, which is the trail around the school. And then you get a little book that has every possible language on the face of the earth. So because they're known for their instruction in language. And my daughter didn't get that memo, but immediately went to Spain after she graduated, not knowing a word of Spanish, after going to one of the premier schools for languages in the country, but that's a different story. And then after college, Dr. Callaghan attended medical school here, and she tells me she had most of her classes right in this room. So she may have a little bit of PTSD from that. But what we really know Dr. Callaghan about or from is her work with pregnant individuals who have substance use disorders. And her reputation is really not to be minimized. When I was still at Yale, I sought out Dr. Callaghan to be on a grant that I was writing. And she was really instrumental in that, both writing the grant and obtaining it and doing it. So, you know, her reputation certainly is not limited to Massachusetts, but it was a little bit of a problem because we were trying to compare two different interventions and we needed people who didn't know the interventions. And of course, Dr. Callaghan knew it. She was trained in prescribing buprenorphine and all sorts of things. And then she like scooped up half of the patients that would have been appropriate for this study into her green clinic here at UMass. So we had some trouble finding some sites in Massachusetts, at least locally. So let me tell you a little bit about that work. So Dr. Callaghan actually founded the Karen W. Green Clinic for Pregnancy and Recovery, which is a multidisciplinary clinic that provides prenatal care and co-located addiction treatment from Dr. Callaghan and others. So it's a real jewel here. They really try and optimize and integrate both obstetrical and postpartum care. So they provide medication-assisted treatment right there, and they have peer support as well as other social work and other support. Since joining the Department of OB-GYN in 2014, Dr. Callaghan has led a committee of nurses, pharmacists, addiction specialists, and administrators in drafting and finalizing and implementing inpatient protocols for medication-assisted treatment for pregnant individuals who are being treated with both methadone and buprenorphine. And those protocols have actually been shared with other hospitals in our system who contact Dr. Callaghan for advice. I could go on and on. She's a member of the Crisis Task Force. She's involved with the American College of OB-GYN's Opioid and Addiction Medicine Task Force. You're a master trainer in buprenorphine treatment. So with that, let me turn it over to Dr. Callaghan. Thank you.
Thank you both for that lovely introduction. Today, we're going to talk about substance use disorders in pregnant and postpartum women. And a lot of what I concentrate on is opioid use disorder because here in Worcester, that's 85% of our pregnant population with substance use disorders. Opiates are the main problem. I don't have any actual or potential conflict of interest in relation to this program or presentation. The general structure is we're actually going to start with kind of a cultural perspective of pregnancy. The view of the mother-baby dyad in 2022 is actually a large part of how we practice. And it's actually a large part of obstetrics. And there are certain sort of thought blocks in treating pregnancy and pregnant women that are hard to get around until you recognize them. You can't really recognize them until you understand like culturally how we got here. And then I will briefly go over substance use disorder in pregnancy, the medications that we commonly use for opioid use disorder, and a little bit about intrapartum management of substance use disorders and postpartum management. So the history behind this is that currently we're trying to work towards a holistic view of a pregnant woman and her fetus. This was not a problem until the past like 200 years. Like in the past, there was the pregnant woman, period. The fetus wasn't considered. There was no separation. This was both legally and medically. In about the 1800s through the 1900s, the viewpoint shifted to a connected viewpoint, where there were two separate entities, but they were connected. Both maternal and fetal interests were considered to be the same and inseparable. So what was good for mom was good for baby, and vice versa. In about the early 1900s, the view came about that there was now a separate existence, meaning that maternal and fetal interests can be separate, but we're almost always the same. This was largely a legal shift, but was also medical. And then in the late 1900s, which I find hilarious because I was a full-blown adult late 1900s, we started developing an adversarial view, which means that mom, the pregnant woman, can harm her fetus and vice versa. And so not only these separate entities, but they can be in opposition to each other. And we are still really stuck there. We are trying, at least as obstetricians, to move forward from that, and we kind of have to. I think the view that we have all internalized is this, and this is being quoted ironically. This is not what McDonald actually believes. This is an article talking about the danger of thinking like this, but good mothers should manage and avoid any risks, thereby protecting their babies from harm and putting their own children's need before their own. They should not allow toxins to enter the body. I think of it as like the pure vessel philosophy of pregnancy. And this is literally everywhere. You cannot get away from this. If you're on Facebook, if you're on the internet, you're going to see ads about the Tylenol settlement. There is no Tylenol settlement. They're trying to drum up lawsuit for Tylenol causing autism. Taking Tylenol in pregnancy is bad. Your baby's going to have autism. Here is a study and response on do labor epidurals cause autism. And this is a cultural perspective you see in the debate of whether to get a epidural or not constantly. What is that epidural going to do to my baby? Am I a better mother if I just deliver in excruciating pain? This is actually a perfectly fine graphic about eating safely during pregnancy. But this is a pretty huge focus of counseling for prenatal care, is how to do something as basic as eat safely in pregnancy. And it says things like avoid hot dogs and lunch meats because the risk is listeria. Listeria is literally everywhere. You would have to avoid food to avoid listeria, but we give women counseling about restricting their diets because they might get listeria. I can tell you the only cases of listeria that I've seen in pregnancy, we've never been able to identify the source. Running while pregnant, is it safe? Yeah, it is. But I can tell you plenty of very fine obstetricians and even our own nurses will counsel patients that they shouldn't do it. Sleeping position. This is a big one. You will see studies on the optimal sleeping position for pregnancy. And there's some very poorly designed studies that show that there is an optimal position. There is not. It doesn't matter. You can't control the position that you sleep in. Mother's laughter helps keep baby feel safe and cheerful. Oh, you guys better laugh enough. Your baby's going to be sad. Can sneezing hurt my baby? Yes. No, sneezing cannot hurt your baby. What are you going to do about it anyway? Can you use nail polish? And it can go on. And it's not just confined to the lay media. We internalize all that. it's, when I was younger, I used to get very frustrated with doctors who would call to find out what was safe in pregnancy until I started looking at what their resources were. How can you figure this out if you're not an obstetrician? If you're not trained in toxicology and pregnancy, how can you figure this out? It is hard. I at least once a year get called, can I give this psychotic patient who is pregnant Haldol because I can't figure it out? Well, gosh darn it, why can't you figure it out? If you go to Up to Date, which I will mock any obstetrician who looks up, obstetrical advice on Up to Date, but I use it for every other specialty that I'm not familiar with. But if you look it up, it says, although Haldol has not been found to be a major human teratogen, an association with limb malformation following first trimester exposure in humans cannot be ruled out. That would give you some hesitation unless you actually opened up the article and read it, where it says the rate of congenital anomalies did not differ between Haldol, Paradol exposed group and the control group. And there were limb deformities in both groups because limb deformities are something that happens in pregnancy, but there was not a difference. Yet that gets translated into, we can't say, which gets translated into an emergency room physician who has to call an obstetrician to figure out, is this safe in pregnancy? So you have all this guilt because you are not a pure vessel in pregnancy, and you might, God forbid, get an epidural when you're in excruciating pain in labor. What about if you have an illness that's as stigmatized as substance use? Those patients are exceptionally vulnerable, are exceptionally stigmatized. There is a hierarchy in the world of people who use drugs, and the pregnant woman is at the bottom. I might use drugs, but at least I'm not pregnant in using drugs. These patients are isolated. It can be difficult to care for them safely if you don't know what you're doing. It's also common. This is not uncommon. This is very old data. It's the best data that we have, but it's over a decade old at this point. It was from a 2012 survey that was not meant to detect substance use, but it was a survey about a number of different medical issues and happened to uncover that 5% of women disclosed using illicit substances. Now that's disclosed. It's probably much higher. In Worcester, it's closer to 10% of pregnant women are using illicit substances. About 10% of women drink alcohol in pregnancy, whether that's problematic use or not, is not delineated. About 15% use tobacco, and in Worcester, it's closer to 25% use tobacco. 10% is about the estimates that we get for alcohol use in pregnancy in Worcester. This is more common than very common problems in obstetrics. So this is not a rare event. So what happens when women who have substance use disorder get pregnant? Compared to the non-pregnant population, they drink less alcohol, smoke fewer cigarettes, and use fewer illicit drugs. Use tends to decrease as the pregnancy goes on. And the greatest reduction is actually seen, the greatest slope of reduction is actually early in pregnancy. You can think of all the women who quit smoking when they discovered that they're pregnant. That's a pretty common thing. They can't quit any other time, but in pregnancy, they manage to do so. We see the same thing with other substances. About 80% of people do resume use after pregnancy. That's based on smoking data. And actually, when they did biologic samples, it was actually a lot higher than that. So relapse is very common. The risks of substance use in pregnancy, I think, are easier to think about in terms of mom and then baby. For mom, it's all the risks of when you aren't pregnant. The additional risk in pregnancy can have to do with the way infectious diseases are treated in pregnancy. There is a very large risk of lack of prenatal care because it can be difficult to seek prenatal care when you are pregnant, which is one of the reasons why I created a clinic specifically for people who had substance use disorder. I think one of the biggest risks is the isolation and the increased risk of domestic violence, which goes for all pregnant women, not just women who use substances. On top of medical risks, the legal risks are very real and very frightening, especially now in the age of the Dobbs decision. We expect that these lawsuits are going to be more common. Women can actually be prosecuted for abuse for using substances in pregnancy. There's risks just with seeking treatments. In Massachusetts, All substance exposed newborns have to be reported to the state. Our reporting mechanism is through a report of abuse or neglect through DCF. So this is even a woman who's only using prescribed substances. If it is an opiate, they have to be reported to the state for abuse and neglect. Never mind if you are using illicit substances and want to seek treatment, you are risking custody. You are risking your family. I had a lovely woman who had 4 years of recovery, relapsed with Percocet in pregnancy, came to me at 28 weeks, disclosed this, asked for treatment. She literally walked in and asked for treatment, immediately went to labor and delivery, immediately got started on Suboxone, followed up with us for prenatal care for the next 3 months, never missed an appointment, was never even late, never had a untoward tox screen, was successfully parenting an 8-year-old until she came to us for help, and the 8-year-old was taken away from her because she disclosed drug use. And then Massachusetts took custody of her infant immediately on delivery. So women aren't, they're not wrong in being reluctant to seek care for substance use disorder in pregnancy, even in Massachusetts. What are the actual effects on the baby? This is the best chart we really have. It's not particularly accurate. The risks for the actual baby in utero are greatest for cocaine, which is mostly growth. A lot of the postulated neurobehavioral effects have not really borne under scrutiny, but there are some growth effects. There's also a risk of placental abruption, which can be catastrophic in pregnancy. We know that there's effects of alcohol. Alcohol probably has the strongest actual effect for birth defects, and fetal alcohol syndrome is a very real thing. I hope I have time to touch a little bit on fetal alcohol spectrum disorders, which is a new sort of idea, which I don't necessarily agree with. When it comes to opiates, there's not actually that much of an effect. I know this chart says that there's a strong, actually, I'm sorry. It says there's some effect for fetal growth and neurobehavior. The neurobehavior, like all neurobehavioral research, is fairly difficult to get rid of the confounding bias. Fetal growth is really associated with withdrawal. People who are frequently in withdrawal from opiates can have growth restriction. But with the opiate themselves, really we don't see much of an effect. There's no proven birth defect. There's no proven analogous fetal alcohol syndrome. The risks are related to withdrawal. We think the withdrawal is not so much dangerous for the baby. The fetus itself seems to tolerate it, but the placenta does terrible. And the placenta is the life support system for the baby. We know there's an increased risk of miscarriage. We know there's an increased risk of placental abruption, preterm birth, and stillbirth. Stillbirth is about 3 times the rate of the general population in somebody who has witnessed opiate withdrawal in pregnancy. We've known that since the 1960s. So treatment for opioid use disorder in pregnancy is important, both for mom and for the baby. What's constantly investigated and what everyone would love would be if abstinence therapy was something that could be safely done in pregnancy, and it cannot. Even the best controlled studies, and this one was fairly aggressive. It was close to 100 women who were offered inpatient detox. The average duration of the detox was 25 days. And it was published as this was a great success because we saw very little, not no, but very little neonatal abstinence syndrome afterwards, which was really the primary outcome. We wanted to reduce neonatal abstinence syndrome. However, they excluded 2 stillbirths, and they included another one. They included a third. So this is still a very high rate of stillbirth, which is also bad for baby. More concerningly is there was a great number of women who were not engaged in treatment by the time of delivery. These were also excluded from the neonatal abstinence syndrome results, but they lost 44% of their participants, which to me is not a satisfactory outcome. When we use medications for opioid use disorder in pregnancy, our goals are the same, outside of pregnancy, but also to decrease the high risk activity associated with it, to reduce the risk of relapse, but really our focus is to minimize withdrawal. That withdrawal is what's dangerous. And so can we minimize how often, how frequently, and how severely she is withdrawing? Methadone, as I'm sure you know, is the gold standard in pregnancy. Because it's been studied for the longest, we have the most long-term data. Our data on buprenorphine is getting longer and longer, but we still don't have the 50 or 60 years experience that we have with methadone. It also seems like in the studies, particularly the comparative studies between buprenorphine and methadone, that methadone has higher retention rates, at least for pregnancy. Buprenorphine has been proven to be a very safe alternative, though. The mother trial was really the big study that helped everyone be comfortable with this. It was, it might be a little bit of a sidetrack, but again, they used buprenorphine. They used the mono agent. They didn't use the dual agent because what if that naloxone could have an untoward effect on the fetus? And when I was first training, the dictum was that you only use the mono agent in pregnancy because you didn't know if the naloxone was safe. Never mind that the naloxone was barely metabolized if it was used correctly. Never mind that there's really no indication that the naloxone would be unsafe in pregnancy. But hands off, because there could possibly be theoretically a risk to the fetus. Meanwhile, it was hard to get. It was hard to get insurance coverage. It was hard to titrate. You couldn't dose adjust very easily because you needed to have the prior auth in advance. Luckily, we have moved away from that. There's been plenty of work on how the dual agent is safe in pregnancy, and that's actually what we prefer at this point. The safety for the baby was well proven. There was sort of a higher rate of dropout in the buprenorphine wing than expected. And they really were using very low, they started with 2 milligrams of buprenorphine. They titrated up very slowly. I think the average dose by the end of the study was something quite low. And so it's been postulated that the doses were just really too low. And so that 33% of women randomized to buprenorphine who didn't complete the study, this has been replicated and they do not see the same dropout rate. It probably had to do with the actual dose of buprenorphine. When women are on medications for opioid use disorder and pregnancy, we anticipate and expect a dose increase by the end of pregnancy. Most commonly, this happens in late second trimester, but sometimes it's needed the earliest first trimester. Sometimes women are still titrating up at the end. We do this with blood pressure medications. We do this with insulin. Part of the problem is the change in metabolism, the rapidly changing metabolism. For a variety of reasons, the pregnant person is breaking down substances and excreting them much faster than the non-pregnant woman. And that changes. It doesn't just happen. She's pregnant. It's a new metabolism, end of story. It's a progressive process. And so we expect dose increases. This often takes a lot of counseling for patients, particularly patients who have been stable for a long period of time. They see dose increases as a step backwards. They see dose increases as dangerous for their baby. Again, it's that internalization that one must be a pure vessel in order to be a good mother. The good news is that increased doses of buprenorphine or methadone do not seem to correlate with an increased rate of or severity of neonatal abstinence syndrome. Being on a higher dose of methadone than at the end of pregnancy compared to the beginning does not mean that your baby is more likely to experience neonatal opiate withdrawal, nor are they going to need more medication if they do happen to be treated for neonatal opiate withdrawal. It's not how it works. Now, if you look at somebody who's on a very low dose of methadone versus somebody who's on a very high dose of methadone, you might see a difference, but people don't usually jump from one category to the other over the course of pregnancy with rare exception. I find that this is very important to reiterate to the patient because pregnant people can be reluctant to report symptoms, thinking that they might have to be increased, or they could be seen as being a bad mom. And so it takes a lot of counseling to get women to understand that it's the withdrawal that's dangerous. We need to know we can treat it, and you're doing the right thing by treating it. Naltrexone, given that it has a different mechanism of action, is a little different. We do prescribe naltrexone for women in pregnancy. If that's what she comes in to the pregnancy on, feels safe on it, is doing well, there's absolutely no reason to discontinue it. We consider it sort of a second line agent in pregnancy if somebody is choosing a medication for opioid use disorder. And the reason being, she's going to have to go through withdrawal in order to be on the med if she's actively using opiates. I've had patients who've had, abstinence. Pregnancy does a lot, including vivid dreams. Drug dreams are extremely common. I had a patient recently who had years of sobriety, got pregnant, and was having very vivid drug dreams. And she wanted Vivitrol because that's how she had originally gained abstinence. And I had no problem starting her. But the patient who comes in and might be dependent on opiates, who has to go through a withdrawal in order to get to naltrexone, I often counsel them that, methadone and buprenorphine are likely safer from that perspective. So when we're thinking about medications for opioid use disorder and pregnancy, really the angle to come from, like the most simplistic view, is minimize withdrawal, protect that placenta. I'll continue whatever medications are currently working for the patient. I do recommend starting medications for untreated patients, just like the general population. Patients with opioid use disorder who use medications for opioid use disorder do better than patients who don't. I do counsel about neonatal abstinence syndrome and neonatal opiate withdrawal syndrome, and we'll talk a little bit about that. I also am realistic with patients about DCF involvement. They deserve to know that. So the other quandary we often come into is how to handle pain for patients with opioid use disorder intrapartum. The first sort of task is in prenatally planning. Patients who are on particularly buprenorphine products, but also methadone, are often anticipating difficulty controlling their pain for a variety of reasons. In fact, in the surgical literature, there was, in fact, still is, a leaning towards discontinuing these medicines before a procedure in order to optimize pain control afterwards. The policy, believe it or not, this was UMass's policy up until maybe 2 years ago, maybe a year. Very recently, during COVID times, is when we actually changed the pre-surgical counseling. Was if you're going to have surgery, you should stop your medications for opioid use disorder, anticipation of needing opiates to control your pain afterwards, and those opiates will work better. It's terrible. It's very risky. It's also unnecessary. It's very unnecessary. There has been plenty of research since the 2004 expert consensus guideline that advised that particularly patients who are on buprenorphine should stop their buprenorphine products before surgery. It was based on expert opinion. It was very well couched in a lot of language saying, we don't know, this is all theoretical, more research should be given, blah, blah, blah. That research has been done and is very clear. Pain control is very possible, even continuing your Suboxone, your Subutex, your methadone. Epidurals, this is a big fancy data for the anesthesiologist showing that epidurals are just as effective for the patient who are on medications for opioid use disorder as a control group. We do know that after vaginal delivery, really in the postpartum period, vaginal delivery, they don't need anything different than a person who's not using medications for opioid use disorder. We don't typically use opiates for postpartum pain control after a vaginal delivery. NSAIDs work much, much better, are generally all that somebody needs. Heating pads are great too. However, when it comes to C-sections, which is major abdominal surgery, it is a common surgery and people often mistake it because it's so common as a simple and easy surgery. No, I could describe it for you in detail, but it's lunchtime and I don't want to do that to you. It is big and people do need opiates in order to be able to function after a C-section. We find that patients who are on methadone need about 70% more oxycodone equivalents than patients who aren't on methadone. Buprenorphine patients require about 50% more. That sounds impressive until you do the math. So the average patient after I'm going to simplify some of this a little bit. The average patient after a C-section is written for 10 milligrams of oxycodone every 4 hours. So our patients who are on medications for opioid use disorder, we write them for 15 milligrams. It's not that much. And they actually do wonderfully as long as their pain is actually treated. Again, you can imagine, given the cultural context of the pure vessel and the good mother, not to mention the cultural context of the patient who has opioid use disorder asking for pain meds, this can be very difficult. We spent a long time educating our postpartum nurses, our doctors, our labor nurses on the particular needs of the patient who is opioid dependent postpartum, because she's not pain seeking. She's in pain and her pain is harder to treat than your average patient. And we've shown really good results with just automatically increasing the amount of opiate that's available to these patients. I also tell patients that aggressive pain control the day of surgery and the day after really makes the number of days that somebody is going to need opiates for pain a lot shorter. And I can tell you the vast majority of patients leave labor and delivery after a C-section with a prescription for Percocet or oxycodone. I can tell you that my patients who come through the Green Clinic, only about half of them actually leave the hospital. And I'm not stingy. If somebody feels like they need opiates for pain control, they leave the hospital with opiates for pain control. But we are very aggressive in the beginning, and most people are managing their pain just with NSAIDs by the end. So yes, the CSAT expert recommendation back in 2004, based on theoretical concerns, recommended the discontinuation of buprenorphine products prior to surgery. And this is still the standard of care in most institutions. It was in ours up until a couple of years ago. However, it has since been proven. There is a lack of evidence to actually support this, and there is a plethora of evidence that shows that pain can actually be controlled very well with modest increases in opiate equivalents. So after a cesarean delivery or after surgery in general, or in preparation for surgery, I tell patients to continue their medications for opioid use disorder, to anticipate an increased opiate requirement, make sure that at least in our institution, her pain will absolutely be treated. And a lot of this, the success of this was dependent on a lot of staff education. Postpartum, she's had the baby, now what? Unfortunately, we see high rates of relapse. For opioid use disorder, this is poorly studied for all the same reason that long-term studies on opiate use disorder are difficult. We do have some studies on smoking cessation with smokers, people who quit in pregnancy. About half, a little more than that, up to 80% in some studies report resumption of smoking after delivery. But if you use biochemical markers, it's closer to 90%. The population of patients who have substance use disorder also have much higher rates of postpartum depression. In the general population, it's about 12%. In our population, it's 40 to 60%. We'll actually have an episode of postpartum depression. And so increased surveillance during this period for postpartum depression is important. ACOG recently advised that patients who are at risk for postpartum depression of greater than average risk should really have a visit at 2 weeks. Our standard of care is after you deliver, we see you 6 to 8 weeks later. But for patients who are at risk for postpartum depression, we see them at 2 weeks. In my clinic, in the Green Clinic, we see patients every 1 to 2 weeks after delivery, and we do that for a good 2 to 3 months. Other considerations, other reasons we see people frequently are, especially if she has been prescribed an opiate for pain control, what we believe in for all patients is a short script of opiate is better than a long script. And for our patients in particular, it can be very emotionally difficult for them to go home with an opiate, especially if their original disease was triggered by using pills. And so we have a very, very close eye on them. At the same time, we really don't want to discourage women from using pain medicine because untreated pain is a much bigger risk for relapse. So we do a lot of counseling around that. I know this picture is a little graphic. I show it to people just because people do forget. Like C-sections are big. They're big and they're difficult surgeries. So a lot of the consideration in treating a woman for opioid use disorder in pregnancy and postpartum is geared around neonatal abstinence syndrome, baby withdrawal after delivery, and with opiates specifically, neonatal opiate withdrawal. This became a big problem in the earlier part of the last decade. When the opioid epidemic really took off, we started seeing increased rates of neonatal opiate withdrawal. And NICUs were overwhelmed. At one point, it was a quarter of our NICU population with babies that were thought to be withdrawing from opiates. In future literature, you're going to see decreases in this. And unfortunately, it's not because we've solved the opioid epidemic. It's because our approach to neonatal opiate withdrawal has changed. The Finnegan scale came about, I don't remember, 70s, 80s, and was supposed to assess the severity of neonatal opiate withdrawal. However, it became a tool of diagnosis. If you scored above a certain level on the Finnegan scale, the baby was considered to be in withdrawal. This is not how Loretta Finnegan developed this tool, is not how it's meant to be used, but it's how everybody, including UMassMemorial, used the tool. Unfortunately, it's not as objective as one would like. And unfortunately, a lot of the behaviors that were described are just things babies do. Sneezing, vomiting, crying. These are babies acting like babies. But in the context of exposure to opiates, it could very easily be turned into, oh, this is withdrawal. On top of that, it is much easier to give a patient a medication than to comfort them. And so it's very easy to write a protocol. A baby has a Finnegan score of 12, baby needs this amount of morphine. And because they were trying to avoid withdrawal, giving morphine meant starting a morphine taper. And so 10 years ago, even 5 years ago, the protocol was if a baby scored a certain amount, they were started on a morphine taper. And that meant they'd be in the hospital for, I think the average was like 17 days, a long period of time. We approach things differently now. The standard of care for evaluating neonatal opiate withdrawal is now the baby's functionality. How is the baby functioning in its job as a baby? Can the baby eat? Can the baby sleep? Can the baby be consoled? And if a baby can do those things, baby does not need medication. First line treatment now is not morphine or methadone or another opioid concoction. First line of treatment is swaddle the baby, swing the baby, feed the baby, comfort the baby. Neonatal abstinence syndrome babies requiring treatment. It was about 80% of babies who were born to a mother who was dependent on opiates in pregnancy required medications. Now it's down to about 25%. So it's much, much lower. So you're going to see this. You're going to see this great big drop. It actually has to do with our approach to neonatal opiate withdrawal. I might have dropped these in. I like to do the language a little bit. It becomes important, especially when advocating for your patients. But a substance exposed newborn, or SEN, is a fetus that was exposed to alcohol or other substances, whether or not exposure is detected or not. And the reason that last part is put in there is if mom says she was using a substance, that is a substance exposure. Neonatal abstinence syndrome is a pattern of effects associated with substance withdrawal, and they include SSRIs in that list, and this is a problem for a number of reasons. But neonatal opiate withdrawal syndrome is specific to opiates. So you might see NAS, you might see NOWS, those are specific meetings. The reason I tend to hesitate on SSRIs is the data on an actual withdrawal syndrome is extremely poor. It's extremely biased. There's not a standard diagnostic feature for SSRI withdrawal in the newborn. There's not a standard treatment. There's no untoward long-term outcome that anybody has come up with. Highly suspect, or at least this kind of condition is ripe for just being subjective. And so I'm very, very careful with that. Women are already reluctant to take their SSRIs in pregnancy, hearing that there might be a withdrawal syndrome. That might be the end of her being willing to treat her anxiety and depression. Fetal alcohol spectrum disorder. So there's fetal alcohol syndrome. There is a pathognomonic facies. There are absolute neurobehavioral consequences. That is something we've known about for a long time. There's a move, and ACOG is on board with this, unfortunately, to reclassify a fetal alcohol spectrum disorder. It's a wide range of effect that can occur when a fetus is exposed to alcohol in utero. They are including autism, ADHD, a wide range of diagnoses, which if are diagnosed in a child later on in life, and the child was known to be exposed to alcohol in utero, they're now saying this is fetal alcohol spectrum disorders. Again, this is ripe for subjectivity, and it's ripe for abuse. Fetal alcohol syndrome is different. I'm not saying there's no such thing as fetal alcohol syndrome. There absolutely is. Scary thing about that is we can't say what the threshold is. We don't know if exposure at a certain point in pregnancy is more likely to result in fetal alcohol syndrome. Is first trimester worse than third? Probably, but we don't know. We don't know if there's an amount. Is drinking 1 drink a day okay? 2 drinks a day okay? We don't know. And so the general line is there's no safe amount of alcohol use in pregnancy. Neonatal opiate withdrawal syndrome. So it used to be 60 to 80%. You will still see this number quoted in literature. It is actually much, much lower in newer studies of exposed infants exposed to opiates in utero will develop neonatal opiate withdrawal. The symptoms are high-pitched cry, irritability, sleep-wake disturbances, alterations in tone, feeding difficulties, GI trouble, all of which leads to failure to thrive. Long-term effects, very, very unclear. Probably nothing. There probably are not long-term effects. Going through a withdrawal as an infant most likely has no effect. I put this picture on here because experienced pediatric nurses will always tell me that this is the picture of a child in neonatal opiate withdrawal, high toned. The full picture shows how underweight this kid is. Fists are clenched over by the face. This is my baby. This baby was not exposed to opiates. This baby was exposed to a lot of caffeine. This baby was not exposed to opiates in utero. And that's the danger of having what is supposed to be an objective scoring system, which is actually quite subjective. And we saw this not infrequently. And the where I really got skeptical was I had a number of patients who had cocaine use disorder, were very open with me about their cocaine use. I would have months of toxicology showing their cocaine use. We're not using opiates. I had objective proof that they weren't using opiates. Really subjectively, they told me they were using cocaine. Why would they lie about the opiates? Yet they would end up getting observed and even treated for neonatal opiate withdrawal syndrome because they scored on the Finnegan, which never should have been given to them in the first place. So really do have to be careful with how we use these tools. We do know, so when the woman is deciding, am I going to start medication? Am I not? I'm worried, I'm opioid dependent. What am I going to do to my baby? This neonatal abstinence syndrome sounds so scary. Is there anything that I can do? You can get your medications adjusted as needed because that has no effect. There is no dose relationship between your increase in methadone dose and neonatal abstinence syndrome. But there is a dose-related relationship with tobacco. So even if you can cut down on your tobacco use, you are going to decrease your baby's risk of neonatal abstinence syndrome. You're going to decrease the severity if baby is actually diagnosed. And I like to put it that way because it'd be great if she quit altogether. That's what I really want. I'll support you in any way. But a more achievable goal, particularly somebody who's in early recovery from using other substances, is even if you can decrease it, you're going to be doing right by your kid. The other thing is breastfeeding. We've known for a while that the breastfed baby was less likely to have neonatal abstinence syndrome or neonatal opiate withdrawal. We weren't entirely sure why. There was an idea that perhaps some degree of the medication that they were using for opiate use disorder was getting through the breast milk to the baby, except that's not true. We've studied the breast milk. We've studied formula-fed infants who are given all the same comfort measures as breastfed babies. And really, it's not the milk and it's not the medications through the milk. It's actually all the comfort that goes with breastfeeding. It's also the babies who were breastfed were more likely being kept with mom, who could pay close attention to cues and comfort the baby as needed. So we do know that breastfeeding can decrease the risk of neonatal abstinence syndrome. The standard of care is for baby and mom to room in after delivery so that mom can pay attention to those cues, comfort the baby as needed. Unfortunately, DCF or the pediatrician might weigh in on this. And DCF might say she can't breastfeed. And if she chooses to breastfeed, because that's what's best for her baby, and the doctors agree with her, she's risking custody. And we've seen this happen. And we've seen this happen not just with opiates, but we've seen it happen with marijuana. And so as strident as I am, and I'm wearing my Doc Martens, you might get an idea that I'm a little bit of a, agitator. Got to be careful how you agitate and how you counsel women. DCF says they don't want her breastfeeding. There's really not much of an option. This is just showing about how formula-fed babies might have a longer hospital stay than exclusively breastfed babies. This data has been redone recently with more closely replicating all the behaviors that go with breastfeeding, and really there's much less of a difference. So if the baby is fed, that's great. If baby is comforted by a parent, it's even better. We get a lot of questions about, can I breastfeed and take amoxicillin, take my SSRI, and can I breastfeed and still take methadone and Suboxone? And it's absolutely, the amount of buprenorphine that actually gets into the breast milk is minimal. That's also, it's the under the tongue, it's swallowing it. You get very little of the active substance. Same goes for breastfeeding. With methadone, same thing. It's not readily bioavailable through the breast milk. Yet, for the woman who I have convinced, or for the patient who I have convinced to stay on or start methadone or buprenorphine, to avoid that withdrawal in pregnancy, there's still a subset of patients who do not want to be on these medications. They are willing to do it in pregnancy to avoid that withdrawal, but now they want to get off their medication for opioid use disorder. And I bring up this picture. These, again, my kids. This was the night I returned to work. It was about 6 weeks postpartum. I asked my husband how things were going. He sent me this picture, which is one kid that he's not supporting her neck and she's just dangling off his lap. And one kid in the tub, like basically unsupervised, and he's written red rum on does everybody know The Shining? Yeah. People know The Shining? Okay. So he's written red rum on the tongue. He's like, it's great. It's fine. Postpartum is chaos. It's a horrible time. You are not sleeping. You are not eating. It is a major life shift. Like, this is not a great time to change your medications in any way. I tell people, like, it's not methadone and you guys know this better than I do, but methadone and buprenorphine do not have to be lifetime medications. It's okay if they are. You have a lifetime illness, chronic illness, it's okay if you take medications for the rest of your life, but they don't have to be. But you're really going to need to make some major life changes in order to be stable off of the medications that got you so healthy. And I liken it to a diabetic who's managed to like change their diet and exercise and lose weight and do like all these things. And now they don't have to take their anti-glycemics anymore. It can happen. Postpartum is not the time to do that. I usually try to get women to wait 2 to 3 months before they consider coming off of their medications. However, if she chooses to go off, I would much rather she do it with me in a supervised, supportive way than just do it on her own. So I do let my patients make their own decisions. The obstetricians are waking up to substance use as a major contributor to maternal morbidity and mortality. Close to 20% of all deaths in pregnancy are substance use related. It actually recently became the leading cause of accidental death in the year postpartum, which was startling to a lot of people. And what's really scary for obstetricians is most of these deaths are occurring late postpartum. So it's not in the time period that obstetricians typically follow patients. It's 6 to 12 months after delivery when they've left our care. And so I consider a lot of short interval follow-up, and I also follow these patients long-term. So I will follow them for, 1 to, I think my record is 4 years after they delivered, trying to keep people stable. So in short, substance use disorder in pregnancy is common. It's increasingly common, and it's probably more common than we know. Pregnant patients can and should be treated for substance use disorder. I would continue any medications for opioid use disorder, pregnancy, intrapartum, intra-delivery, and postpartum. Postpartum state is actually a high risk state. And these patients bear close watching and close follow-up. And breastfeeding and cuddling is very beneficial for substance exposed newborns. That's it.
We have a lot of questions on this from the Zoom world.
Okay.
I don't know if anybody had one in here, but I can start reading them.
Okay.
Is there a recommendation for PO versus IM naltrexone? You said, scroll down. You said few doses often needs to be increased later in pregnancy. Would IM naltrexone need to be more frequent later in pregnancy?
We have not noticed that. Honestly, it seems like people who come in on doses of naltrexone are stable. The PO versus IM is a fascinating question for a geek like me. And the reason it's interesting is because at the end of pregnancy, something excruciatingly painful is going to happen, and you're going to need opiates to control that pain. And unlike methadone and Suboxone, the actual blockade from the naltrexone is difficult to overcome. So what we typically do is if patients are on IM naltrexone is we transition them to PO at about 36 weeks or about a month before delivery is anticipated. And that way we can discontinue it when labor is anticipated so that they have pain control options. I have had patients decline that and they just continue their Vivitrol and they do okay.
Another question, how much do you think the thalidomide crisis of the 1950s and 60s may still influence some of the current concerns with refraining from any, quote, non-pure, unquote, substance during pregnancy?
It has been a huge influence. It is what is always quoted when there are concerns. Now, this is a fun one. So thalidomide was meant to treat nausea in pregnancy. We did not have another pregnancy-related anti-nausea medication until the past 10 years. We've known forever that diclegis, which is Unisom bundled with vitamin B6, was perfectly safe, but no pharmaceutical company was willing to manufacture and market it. And it was because of the thalidomide crisis. So yeah, it hugely influences decision-making on a lot of different levels in healthcare.
Your thoughts on fetal cannabis spectrum disorders gaining momentum with national marijuana trends?
I think that whenever somebody says spectrum disorders, I start internally cringing because it is so wide and we are opening doors to sort of pigeonhole things to a degree that can be very dangerous. I do not think we yet know the influence of cannabis and cannabinoids on fetal development. There is reason to think there could be influence because the endocannabinoid receptors are part of embryogenesis. Yet we have not yet noticed a constellation of birth defects or neurobehavioral problems or labor difficulties or pregnancy difficulties that are attributed to marijuana users or cannabis users. So it's tough. I think one of the good things about legalizing marijuana is we are finally going to get some research on these patients. But I have a hard time with spectrum disorders that are attributed to maternal behaviors.
Just an editorial comment. The drugs do affect the adult brain.
They can affect the adult brain. The kid's brain is a lot more plastic.
Right. Yeah.
It is a lot more plastic.
Are there any local groups advocating for mothers seeking care to stay with their babies? Any collaborations between OBGYN and PEDS on this?
There is some collaboration with OBG and PEDS. There's more collaboration with OB and community groups. We are very close with a number of activist groups, including LIFT, who Kim knows, who are survivors of commercial sexual exploitation, where there's a high population of opioid dependence. And actually a lot of the activism is coming from community groups. ASAM just released a statement. Did you guys see this week on pregnancy and substance use disorder? And it is very strongly worded, more so than anything ACOG has ever come out with, about the importance of separating the reporting of substance exposed newborns with the reporting of abuse and neglect. So if you guys haven't read it yet, I highly recommend it. It's excellent.
You mentioned many women require dose increases during pregnancy. Is a dose reduction of MAT typically required postpartum? If so, what data do you base this decision on? For example, symptoms?
That is interesting. So more so with methadone, we've noticed. It seems like once women go up on their buprenorphine, they tend to stay at the dose postpartum, unfortunately. With methadone more so, there is dose reduction afterwards. It usually occurs about 4 to 6 weeks after delivery. That's when women start noticing symptoms, which is what we base it on. And it's largely like somnolence and fatigue.
Another question, you mentioned postpartum is a high risk for relapse. Are there any evidence-based psychosocial interventions to address co-occurring postpartum depression and substance use disorder?
Not specific for the substance use disorder population. There are interventions, and in fact, medications for postpartum depression. So typically the patient with substance use disorder who has postpartum depression, you treat as postpartum depression.
Well, that's all the questions on the Zoom.
We're gonna have a fire drill and
We made it with 2 minutes to go to the fire drill. Thank you very, very much.
pleasure. Thank you for having me. I appreciate it.